Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes. So, we will move forwards and begin. Today, we will discuss about the normal chest X-ray anatomy. So, to know abnormal, first you should know normal. So, let's begin with the name of Almighty. So, this is a table which shows the normal components of a chest X-ray. So, as you can see, category and key points: soft tissues and bones. In that, check for symmetry. This is very important point. There are two sides, left and right. So whenever looking for an abnormality, you should check for symmetry. Any asymmetry points towards an abnormality, and look for any rib fractures. Identify any lytic or blastic lesions. Then see the pleura. Pleura is normally invisible, but we should see the cardiophrenic angles. They are sharp and acute. Fissures are also very important, very important, because fissures what they have a role in consolidation and collapse. Okay, right horizontal fissure separates the right upper lobe and right middle lobe. Remember this point: right horizontal fissure separates the right upper lobe and right middle lobe, whereas oblique fissure, both right and left, separate the upper and middle lobes from the lower lobes. So right horizontal fissure separates the right upper lobe from the middle lobe, whereas the oblique fissures of both right and left side separate the upper and middle lobes from the lower lobes. Okay, then you will see the hila. Left hilum is usually 1 to 2 centimeter higher than the right. And what are the components of that hila? Vessels and normal nodes, which are not visible. Normal nodes are not visible, but if there is any lymphadenopathy or lymphadenitis, mediastinal lymphadenitis or cervical something like that, then we may be able to see those large lymph nodes as fullness of the hila. Then we will see the lung parenchyma and lung vasculature, the components of lung parenchyma. Okay, so to see lung parenchyma, we divide the X-ray into zones like upper zone, middle zone, and lower zone. These are descriptive, not anatomical. These serves as descriptive purpose, not anatomical purpose. So whenever seeing the lung parenchyma, we divide the chest X-ray into upper zone and middle zone and lower zone. Then we compare the left upper zone to the right upper zone, then left middle zone to the right middle zone, then left lower zone to the right middle zone. So gravitational effect is a normal thing. What that means? Lower zone vessels are larger in an erect PA film. Remember, the lower zone vessels are larger and they are denser, larger and denser than the upper zone vessels, which are shorter and lighter than the lower zone vessels. And similarly, at the periphery, the vessels are lighter and lighter and what do you call, small in diameter when compared to the center. At the center, they are denser and larger when compared to the periphery. So you should remember this difference. Cephalization is opposite. What happens? Normally there is the lower zone vessels are larger and denser, but cephalization means the upper zone vessels will become larger and denser, and that points towards the pathology. Example, a heart failure, pulmonary edema. Okay, heart failure, that is known as cephalization. What is cephalization? So the normally the upper zone vessels are not uh, denser and larger, but in some pathology like in heart failure conditions, the upper vessels become larger and denser because of hyperdynamic circulation. Okay, so that's these things we have learned: soft tissues and bones, pleura, costophenic angles, fissures we will see, then hila we will see, then lungs, zones, and vasculature. Okay, this we will see. Then we will see mediastinum. So how we will see mediastinum? In mediastinum, we should see these things. Okay, cardiothoracic ratio, number one, some lines, important lines. Okay, we'll discuss those lines, and then compartments. In cardiothoracic ratio, it is normally less than 0.5. Okay, on a PA film. If it is more than 0.5, then it is known as cardiomegaly. In lines, they are subtle, means they are very minute changes, but they are very much critical. There is something called as right paratracheal stripe. We'll discuss in the images. Okay, that is less than 4 to 5 mm, nothing but 4.4 to 0.5 centimeter. okay, in width, okay. It is in the right side. In the left side, we should see the convexity of the aortic pulmonary window. So above will be aorta, below will be pulmonary veins. It will be like this. So this is normally concave. This is normally I will show in the chest X-ray. If it is convex, it becomes convex, then it indicates some nodal enlargement or some mass in that area. Okay. So these things we'll see. We'll see the right paratracheal stripe, then we'll see the aortic pulmonary window. Okay. These are important. Then, so cardiothoracic ratio is seen, lines we have seen, then compartments. Okay. So in compartments, we divide. So it's compartments. There are dividing into compartments are based on two classification. Number one is Felson classification. Number two is ITMIG classification. ITMIG classification is more commonly used, but it is not more useful in chest X-ray. It is more useful in this CT scan and all. But depending upon these two classification, we divide the chest X-ray into prevascular, nothing but anterior compartment, visceral, nothing but middle compartment, paravertebral, just what do you call, beside the vertebra, posterior compartment. So this is useful for differential diagnosis of mediastinal masses. Okay, so cardiothoracic ratio, then lines, then compartments. Compartments, remember, we see in lateral X-ray, lateral chest X-ray film. Compartments we see in this lateral chest X-ray film. Okay, so these are the things. Now we will see the images. So first we should see the symmetry whenever you're seeing the chest X-ray. Now see this chest X-ray. Okay, this is a PA chest X-ray. No, how do you say it as a PA chest X-ray? It is a PA chest X-ray because the heart size is not larger. Scapula shadow, see, you can see the scapula shadow, it is outside. Okay, so by this we will say it is a PA chest X-ray. Now we should see the RIP, rotation, inspiration, and what do you call exposure. Okay, so trachea, see, it is central, and trachea is central, and both the clavicles are equidistant, so it is not rotated. And inspiration, you count the ribs. So this is 1, 2, 3, 4, 5, 6, 7. I can see 8 up to. So so this is actually hyperinflated chest X-ray film. Okay, these are anterior ribs. Okay, so normally it is 5 to 7. No, if more than 7, then it is called as anterior ribs hyperinflation. Okay. Okay, now you see the this just thoracic vertebrae just behind the heart, they are just visible, so it is properly exposed. Okay, now properly exposed. Now how you will compare both the sides? You divide the lung into 3 zones. This is the upper zone, this is the middle zone, and this is the lower zone. This is the upper zone, this is the middle zone, and this is the lower zone. After dividing, you will compare the left to right. Okay, now in this video you can see whitishness is more on the left side than the right side. So both sides you can see whitishness. Okay, but that whitishness is more on the left side. This is because as you can see here, and these small things you can see, these are the shadows of the nipple. So these are the breast shadows. Actually, this whitishness is the shadow of the breast, but this whitishness at the left side, which is marked by this red circle, is more than this green circle. So that is because the left breast is denser. Okay, the left breast is denser than the right breast. That means the tissue is asymmetric in the breast. Okay, so that's how you compare between the two sides of the lungs. That's checking the soft tissues, and bones also you should check. So whether you can see any fractures here. See the clavicle, this is the clavicle, this is the scapula. Okay, this is the acromion process, you can see this one. Okay, see the ribs, there is no fracture as such. Okay, no fractures. So right diaphragm is higher than the left diaphragm. Okay, and you can see this is the right hilum, and this is the left hilum, and this is the right hilum, and the angle is like this. Okay, and the right, as I said, the right lower zone vessels are denser than the upper zone vessels. You can see the lower zone vessel are normally larger and denser than the upper zone vessels. Okay, Now we'll move forwards. We'll see different X-rays. Now you see here, this is a chest X-ray of both PA and lateral view. So they have marked it by the pleura by yellow line and bluish line, but normally pleura is not visible in chest X-ray. Now we will follow the protocol to read the chest X-ray. So first rotation rip, so it is properly, it is not rotated, okay. And you can the thoracic vertebra just behind are just visible, and then that is exposure. And if inspiration, now if you count the inspiration, I need to enlarge the and to zoom it in, okay, zoom it in. So if I zoom 1 2 3 4 5 and 6, so 6 I am able to see the anterior ribs, so it is normal inspiration, okay. Now you see these angles, so these are normally acute. That's what we need to see in pleura, okay. So we have seen the soft tissues and bones, and we have seen the pleura, okay. Now we will, and you see the pleura here also, in lateral chest also you will see these angles, okay. Just remember this one, okay. Okay, now we'll move forwards. So fissures are very also important, okay. So remember the horizontal fissure in the right side, this is the horizontal fissure. This will separate the upper and upper lobe from the middle lobe. Horizontal fissure separates the right upper lobe from the middle lobe, and this oblique fissure in the lateral chest X-ray, this separates the upper lobe, middle lobe from the lower lobe at both sides. Okay, so this is the horizontal fissure, and this will be the this is the oblique fissure, and this will be the horizontal fissure. We will see that in the X-ray now. This is a PA X-ray, okay. See in this video, this thin line you can see, this thin line, this thin line, this thin line, this thin line is nothing but the horizontal fissure. And you can see here also this thin line, this is the oblique fissure, this is the oblique fissure, this thin line. If I take this out like this, it is running, okay, this thin line here, this is the horizontal fissure, this thin line, okay. So horizontal fissure and oblique fissure we need to remember, okay. Now moving forwards, coming to the Hila. So how you will see the Hila, you just what you see, the left means this left Hila is normally is the this one, this will be like this, okay, this will be like this. And these are the lower zone vessels, these are the upper zone vessels, these are the lower zone vessels, these are the upper zone vessels, and this is the aorta. Remember, I will show, okay, this is aorta, this is the pulmonary vessels, and this is the aortic pulmonary window. If this is full, this is filling, no, this is enlarged. If this is enlarged, then there is something, either it can be lymph node or mass can be there, okay. Okay, so this is the it is in obtuse angle like this, okay. And if you draw a line like this, so it will be like this in cross, okay. Okay, you draw a line like this, and if you measure the distance from this to this, if you measure the distance, it will be less than 1.5 centimeter. If it will be less than 1.5 centimeter. How? First, what you do, you draw a line, this this angle line, I will mark like this, okay. It is like this, and this is like this. You just draw a line like this. Now if you measure this distance, so this will be less than 1.5 centimeter. Just remember this. Now it will, you will feel it as filled if there is some lymphadenopathy, mediastinal lymphadenopathy or something, or pulmonary congestion, means hypodynamic circulation, like that. You can see fullness in the hilum. Normally this hilum, this right hilum, left hilum is upper side, this right hilum will be lower than the left hilum, 1.2 1 to 2 centimeter, okay, difference will be there, okay. That's about the Hila. So as I said, so we divide the lungs. This is the upper zone, this is the middle zone, this is the lower zone. So the lower zone vessels are denser and larger than the upper zone vessels. Similarly, at the periphery, the density and the diameter will be less than the center. Center, they will be more denser, okay, same thing. And here this third, this one you can see, this C a line is drawn like this. This is the Hila. Okay, this is the Hilar line, like this normally. Okay. Okay, so these are the things we are discussing about a normal chest X-ray, how it looks. Okay, now see this one. Now here it is about this chest X-ray. You see, so you distance the maximum distance between the right heart border and left heart border, so mark it as A, and the maximum distance between the right ribs and the left rib. Okay, means the point, the thorax, the maximum width between the thorax, label it as B. If the A by B distance is more than 0.5, then it is cardiomegaly. Okay, and one important point I want to see is when there is left ventricular enlargement, this is the left border of the ventricle, and this is the dome of the diaphragm. This is diaphragmatic dome, and this is the left ventricular border. Okay, so when there is left ventricular hypertrophy, so what will happen is this left ventricle will be pushing the dome of the diaphragm downside. So this angle, obtuse angle, will become somewhat like this, like this. It will go towards perpendicular side. The obtusity will be lost. Obtusity will be lost when there is left ventricular enlargement. And opposite to that, when there is right ventricular, this is the right ventricular border which is touching the dome of the diaphragm. So when there is right ventricular enlargement, it will be like this. Okay, you will see the angle like this, acute angle. That will be a clue. Okay, so that suggests right ventricular enlargement, and if this left ventricular enlargement is there, it will press the diaphragm downside. Okay, okay, that's about the cardiothoracic ratio. And remember one thing, if the cardiothoracic ratio is less than 0.42, it is often called a small heart syndrome. It can be seen in cachectic states, adrenal insufficiency, heart transplant, and other conditions. In cachexia, in adrenal insufficiency, in heart transplant, and other conditions. So similar to cardiomegaly, there can be small heart syndrome, something called as small heart syndrome, wherein the cardiothoracic ratio will be less than 0.42. Okay, the causes can be cachexia more commonly, and adrenal insufficiency, or heart transplant. Okay, okay, so normally that means the normal range of that A by B is 0.42 to 0.5. So if it is more than 0.5, it is cardiomegaly. If it is less than 0.42, then it is small heart syndrome. Now I said no, something called as tracheal lines. So this is called as the right paratracheal, this line, paratracheal stripe. This is composed of the right lung pleura, mediastinal fat, and then the tracheal border, tracheal air. So that these three these three components are known as the right tracheal strap. So what is the importance? When there is a mass or something like that, this will be enlarged. This will be something like this. I will show. It will not be straight. It will be like this, something like this. So when the right tracheal stripe is enlarged, so you should suspect any mass or something or node, and you can order CT scan for confirmation. Okay, and this is the left tracheal stripe. And I said no, aortic pulmonary window. So see, this is the aorta. This bulging, no, this bulging is the aorta, and this is the pulmonary artery. Sorry, this is the aorta, and this is the pulmonary artery, and this is the aortic pulmonary window. Okay, so if this is also something is filling this point also, then it can be any mass or nodal enlargement. That's the importance. Okay, so same thing you can see in the CT scan. So this is the left paratracheal stripe, the components you can see. So it is left pleura, left lung pleura, and mediastinal fat, and then air. Okay, and right side you can see the aorta and pulmonary. This is the aorta, this is the pulmonary vessels, and in between them you can see that this is the aortic pulmonary window. Okay, if something is filling that, then there is abnormality. Then that suggests abnormality. Now lastly, we discussed in the mediastinum. These are all about the mediastinum, no? Cardiothoracic ratio, these lines. Okay, and one more thing, I uh, I said about left ventricular enlargement, right ventricular enlargement. So when there is right atrial enlargement, this border, this is nothing but the border of right atria actually. This is the right atrial border. So this will be enlarged in case of right atrial hypertrophy. This will be enlarged in case of right atrial hypertrophy. Okay, and this small thing is, no, this small border, this is left atrium. I will just mark this is left atrium, this is left ventricle, and this is right ventricle, and this is right atrium. Okay, and okay, I will take this down. And small bulging, so you're not able to appreciate here the bulging. Okay, say this is the aorta and this is the pulmonary arteries, this is the right atrium, and you're not able to appreciate here aortic pulmonary window. I think this one is the aorta and these are the pulmonary arteries, something like that. Okay, okay. So lastly, we components, mediastinal compartments. So I said there are two classification. Number one is Felson, number two is ITMIG classification. So what is the difference? So the markings are different. So in Felson classification, the marking is like this. The first marking is like this, and the second marking is, so this is the anterior compartment, middle compartment, and this is the posterior compartment according to Felson. In case of ITMIG, just remember this, the first line will be marked like this. This will be the anterior compartment, this is the middle compartment, and this will be the posterior compartment. So this is not useful in chest X-ray actually. This is more useful in CT scan, as you can see here. Okay, this is the anterior compartment, this is the middle compartment, and this is the posterior compartment. Okay, I'm not going to detail into that. Just remember this ITMIG classification, Felson classification. Now, what and all we have discussed? We have discussed about the how to see the chest symmetrically, how to see the pleura, and about the fissures we have discussed, about the Hila we have discussed, and about the zones of the lung we have discussed. Okay, and mediastinum widening we have discussed, about the cardiomegaly and left ventricular enlargement and right ventricular enlargement, aortic pulmonary video, right paratracheal strap, left paratracheal strap, and the compartments of the lung. Okay, now we will discuss about a very important sign in the chest X-ray, that is Silhouette sign. Silhouette sign. So what is Silhouette sign actually? A core radiological principle. The loss of a normal anatomic border. Silhouette is nothing but border. Okay, silhouette is nothing but border. The loss of a normal anatomic border silhouette that occurs when two structures of the same density, example water or soft tissue, are in direct physical contact. That is Silhouette sign. That is Silhouette sign. We will know that. Okay, we will know that. So remember, before going on to Silhouette sign, I will, so this part I will just remember this part. I will explain this part afterwards. The right hard border is in direct contact with right middle lobe. What that means? If there is something consolidation or collapse in the right middle lobe, already the right hard border is white in the chest X-ray, but the lung parenchyma is blackish because of air. But if when there is consolidation or collapse in the right middle lobe, so the right hard border will be losing its contour. We will not be able to appreciate the right hard border properly in between the lungs and the heart. So that is Silhouette sign. That is Silhouette sign. So we will see when we see this when two structures should have contact. If they don't have contact, we will not be able to see. For example, right hard border. The right lower lobe does not have any contact with right hard border. That's why when there is any consolidation or collapse like thing in right lower lobe, then we will not be able to appreciate the. We will be able to appreciate the right hard border because they are, of course, there is consolidation or collapse, but they are not in direct contact. That's why we will not be able to see the Silhouette sign. Right lower lobe will be posterior, not in contact with the cardiac border. That's why we will not be seeing the Silhouette sign in case of right lower lobe. Okay. Then remember this point. Right hard border is in direct contact with the right middle lobe. Left hard border is in direct contact with the lingula part of the left upper lobe. The left upper lobe has a part known as lingula. When you see the anatomy of the lung, you will know what is the lingular part of the upper lobe of the left lung. So left hard border is contact with the lingula, which is a part of left upper lobe. Right diaphragm is in direct contact with the right lower lobe, and left diaphragm is in direct contact with the left lower lobe. This is important. Why? When there is right middle lobe consolidation or collapse, for example in pneumonia, then the border, right heart border will be obscured. That is known as silhouette sign present. Why? Because right middle lobe directly contacts with the right heart border. So right lower lobe, it is not in direct contact. That's why silhouette sign will not be present. That means there is no obscuration of the border. When there is lingular pneumonia, the silhouette border will be present because it is in direct contact with the left heart border. But left lower lobe, so silhouette sign will not be present. But because the right lower lobe is in direct contact with the right dome of the diaphragm, and the left lower lobe is in direct contact with the left dome of the diaphragm, you will see the silhouette sign in between the lung and the diaphragm, meaning the diaphragmatic border will not be appreciated clearly. So in case of right lower lobe pneumonia, diaphragmatic border will be obscured, so silhouette sign is present. Okay, because right lower lobe is in direct contact with the right diaphragm. In left lower lobe pneumonia, the left diaphragm border will be obscured. The silhouette sign will be present. Why? Because left lower border is directly contact with the left diaphragm. So that's how we make some localization by this silhouette sign. Okay. So we will see, for example, see. So again, the loss of the normal silhouette of a structure on the chest X-ray is called as silhouette sign. Normal silhouette is normal border. This is nothing but border. If you are not appreciating a border, that is silhouette sign. Two episodes of similar densities seen on a chest X-ray are next to each other if their borders cannot be made out. Are not next to each other if their borders are well seen. Silhouette sign is absent. Okay. So see here in this chest X-ray, as you can see, there is consolidation, there is opacification of the left lower zone of the lung, but still you can appreciate the left heart border. That means it is not the lingular part of the upper lobe is not involved. That means it is left lower lobe involvement. Left lower lobe involvement. That means it is left lower lobe consolidation. Left lower lobe, because you are able to appreciate the heart border here. So silhouette sign is absent. So I think here silhouette sign will be present with respect to diaphragm, but in this image he has not given diaphragm, so we can't see. But we can see this heart border. We can make out heart border very nicely. So it is lower lobe consolidation or collapse. Okay, but in collapse you will have that mediastinal shift and pulling up of the diaphragm. In consolidation you will not have that things. Okay, that's how you differentiate between consolidation and collapse and effusion also. We will see in coming images. Now you see here same left side same this, see the left vent, this is the heart. Okay, this is the heart, but you are not able to make out the left heart border here. And see here, this is the left cardiophrenic angle which is present. Okay, and you are able to make out the dome of the border of the dome of the diaphragm, but you are not able to make out the left border of the heart. That means it is lingular lobe which is involved, consolidation of the lingular lobe. As you see, it is given the lingula part, because lingular part of the upper lobe is in direct contact with the left border of the heart. So that left border of the heart is obscured. That means the left lingular part is involved. Okay, simple. Silhouette sign is present. Okay, so this will be the last thing, and then pathology. Next coming images of X-ray will be the pathological images. Okay, we will discuss those images. See here now. So see, this is the memory shadow of the memory glands, breast. Okay, this is the shadow of the breast. Now you see here, you are not able to appreciate the border, right heart border here. Actually, right heart border you are not able to appreciate, but you are able to appreciate the border of the right dome of the diaphragm. That means the problem is the consolidation, and you are seeing the opacification here. So the problem is in the right middle lobe. So it is right middle lobe consolidation. It is not collapse, because in collapse pulls the mediastinum towards itself. So when there is pulling of mediastinum, the trachea will be shifted, but here the trachea is normal, it is not shifted. And the dome of the diaphragm will be pulled and it will become tented. Dome of the diaphragm will become tented. That is not seen here. So it is consolidation of the right middle lobe, because the silhouette sign is present. The silhouette sign is present. You are not able to make out the heart border. Okay, then see this one. Now you see this one. You are able to make out the right heart border, but here you are not able to make out the border of the right dome of diaphragm. That means the pathology is in the right lower lobe. You can see here it is written now, right lower lobe, and it is in the middle lobe. because right lower lobe is in direct contact with the right diaphragm, so you are losing the contour of the diaphragm, so the pathology is in the right lower lobe. So silhouette sign is present, but with respect to diaphragm here. That is with respect to the right border of the heart. So that's about the silhouette sign, and I think it is enough for today. We have learned a lot of things in this video, and in the coming videos we will learn about the pathological things of the chest X-ray. Okay, thank you.